reimbursing you. Okay? So, in other words, before managed care, you paid a premium and then you went to whoever you wanted to see, you paid for it, and then submitted a claim. Just like auto insurance. I mean, you submit a claim if you get in an accident, right? You call, if you have Geico and you get in an accident this afternoon, you call Geico and you in essence file a claim, don't you? So, I got in an accident and here's the details, and they're going to want more details, and so forth and so on. And then you have to go get an estimate, and the estimate will be, say, $1,712 damage to your car. So you might have a deductible of $500, all right? And then the insurance company pays the rest to the body shop that fixes your car, right? Well, health insurance used to be pretty much the same way. You would go and get a service, you would pay for it, and then you would submit a claim to the insurance company. And the insurance company, unless there was something just really, really crazy going on, just paid for the claim. They paid the physician or the provider for the claim. But now a shift in decision making means that insurance companies are now making a lot of the decisions themselves as to what's covered and what's not covered and so forth and so on. And you no longer file claims. You just get the services that the insurance company tells you beforehand that you're allowed to get, and the physician or provider will only provide the services that the insurance company allows them to provide you. There is at least a supposed interest in wellness and preventive care with managed care. We can argue the extent to which that's true or not. But as I go over briefly in a moment the history of managed care, you'll see what I mean and what is the auspices of managed care and how that's working. And then there is transference of risk. In other words, now we see providers actually bearing some risk. And I'll explain that as we talk about different types of managed care organizations in a moment. Now, I'm not going to go into a long history, but managed care actually has been around in some form, even though we didn't call it managed care, for about a century. And there's different things, there's all sorts of things that we can point toward that were said to be the beginnings of managed care, but there's two I want you to pay really good mind to. First, look at the bottom one. There's the Kaiser. So Kaiser, as we know it today, Kaiser Health Plans, was actually begun in around 1937, okay? And how did it have its beginnings? Well, Henry Kaiser and the Kaiser Group was actually some folks that were contracted to build the Grand Coulee Dam. Okay, so these were people that were actually contracted to build the Grand Coulee Dam. And what they did was negotiate with a group of physicians and hospitals for the workers of said dam, since there was going to be hundreds of workers working for years and years to build that dam, and said, can you provide health care for us and coordinate that health care for us and take care of all of our employees if we pay you a set amount of money? Well, that worked out actually. And that actually was the beginnings of Kaiser. That actually was the beginning of Kaiser, and then it evolved. And we'll see some more historical things in just a moment. The other thing I want you to take note of, and this didn't turn out to be managed care until later, but actually just medical insurance, was the creation of Blue Cross and Blue Shield. Actually, Blue Cross. You've all heard of Blue Cross, Blue Shield, right? Okay? And it was a very similar thing. It was a teachers' union in Dallas, Texas. And they went to Baylor Medical Center with a very similar proposition of Baylor providing a comprehensive sets of care to the Dallas Teachers Union for an agreement for set payments up front. That eventually turned into Blue Cross. Everybody understand what we're talking about here? So we're talking about it, these things didn't exist before that time. And you had some employers who wanted to make sure that their employees were taken care of. And they wanted to minimize the risk that each of their individual employees had to take on. Because without insurance, you have all the risk, right? You could be healthy for 10 straight years, then have one calamity that ends up wiping you out, not only clinically, but financially. And so they wanted a company they wanted Baylor Medical Center to take on the risk. Why does Baylor Medical Center take on the risk? Because they have a certain population of people to take care of. And if nobody gets sick, that's fine, Baylor comes out ahead. But what if everybody gets sick? Then Baylor ends up using more resources than what they got paid for. So Baylor Medical Center is then bearing the risk. And this eventually grew into Blue Cross, which later combined with another effort similarly going on around the country with doctors as opposed to hospitals called Blue Shield. And they eventually merged in the 50s to form Blue Cross Blue Shield. Now, as I mentioned to you the first day, there was something under the Nixon administration passed called the HMO Act of 1973. Now, this is what the HMO Act said. It said that for certain employers, and this applied to larger employers. It said for certain employers, particularly larger ones, that if they're going to offer health insurance to their employees, one of the options had to be a federally qualified HMO. Now notice, they did not say that an employer had to provide insurance. It's not what it said. The government doesn't do that. The government said that if you are providing insurance at all, then one of the options must be a federally qualified HMO. And they also established then mechanisms for managed care organizations to become federally qualified. So it established the mechanisms for insurance companies to become federally qualified, and then told employers, particularly large employers, and it's usually like 50 to 100 or more, that if they offered insurance, now let's remember this, because this is an easy test question. Did the HMO Act of 1973 mandate employers to provide insurance to all employees? No, thank you. Yay, good. All right. But still, it didn't really take hold to a certain extent until 1977 amendments to that act. And this was the very important amendment. Now, with regards to insurance, have any of you ever heard of the terms community versus experience rate? Community rate means everybody pays the same, right? Experience rate means that it's based upon experience, or it's based upon factors of some sort. Now, auto insurance, is that community or experience? Experience, right? Because what is your insurance rate based upon? Okay, so your age, even the type of car you have, your past experience as a driver, speeding tickets. They have research that shows people who drive red cars are more likely to be in accidents, so there's more likely a higher charge for a bright red car. Absolutely. They have research that shows the percentage that anyone and everyone is likely to get in an accident in the coming years based upon their race, age, gender, color of car, you name it. They can tell you the likelihood. They can't tell you if you are going to get in an accident. They can tell you the likelihood of you getting into an accident. So it's based upon experience. Now, when the HMO Act first came out, what did they base the ratings on? What's that? Now, who's the customer of health? Who's the customer of managed care organizations? Employers. Okay, it was employers. And at first, they mandated a community rating. Then the HMO amendment said that they can be based upon experience. Now, not experience of the individuals, but experience of the employers. So, for example, one employer, like, how would you compare, say, how would you compare the employees, say, of Google versus an old manufacturing plant? Would they be the same or different? How would they be different? How would the employees of Google be different than the employees of, say, a manufacturing plant? Okay, so working for Google is safer. What about the employees themselves? More likely to be younger, maybe? More likely to be higher educated, maybe? More likely then to be healthy then? Less likely to have health insurance claims than the factory? Probably, right? So the amendments allowed insurance companies to charge an experience rating. So purchasing insurance by an employer by some employers with a good record then allowed them to actually get it cheaper than if everybody had to pay the same amount. Because original 1973 was a community rating. So the 1977 amendments to the 1973 Act really helped to push things along, and actually more so than the 73 Act itself, but these amendments 4 years later really helped to spur managed care along with some other factors. And nowadays, many people are covered through managed care. I mean, a large swath of people in this country are covered through managed care. As we see, employers then kind of fell in love with the concept of managed care, with the prospect that managed care was going to lower the fee for service sort of things that had been going on. We've seen, and then Medicare, as we know, began, and then Medicaid began actually taking on and incorporating managed care into their plans. We then began to say integrated delivery systems, which I'll discuss in a moment. And we had the Affordable Care Act, which Dr. Yoshi has talked to you about pretty extensively, and I think we'll talk with you even more about coming soon. And healthcare, as I've said before, is actually like a lot of other industries. Believe it or not, healthcare often lags behind other industries in the way that their economics works. I've talked to you at least a couple of times a semester about how the market works for, say, pizza and cereal and so forth and so on. And now you have managed care, but now you have all these different types of plans within managed care. And we're going to go through that in just a moment. HMOs, PPOs, EPOs, managed HMOs, hybrids, all of these things are in the market now. So when you go to pick a plan, now sometimes an employer doesn't have a lot of options, but typically most employers have a lot of options. And as you'll see when we discuss the type of managed care plans here in the ensuing minutes, you will see that again, the whole thing is like the market for pizza and cereals and everything else. You have all these choices with everything in between. So let's talk about the different types of managed care plans. So before I even begin, what's the difference? Let's see, who can tell me, who can help start us off and describe the difference between an HMO and a PPO? Those are terms you've probably heard before, right? An HMO and a PPO. So what's the difference between an HMO and a PPO?
HMO, you can only see a certain.
You stay in the network.
You just have to stay in a certain network. The PPO
Okay.
can go out of the.
So an HMO is more confined to being within a certain network than a PPO is. That's one very good distinguishing characteristic. Absolutely. There are a number of differences between HMOs, PPOs, and even other types of plans, okay? Now let's talk, before we talk about the differences between the plans, because I want you to have a general understanding, but there's so much hybridization, I'm not going to emphasize too much the differences between the individual plans. What I want you to understand is the basis by which they might differ, okay? And these are the bases by which the differences are between HMOs, PPOs, and all these other types of plans that we'll at least just casually mention in this class. Okay? So one is risk bearing, and that is who is bearing the risk and to what extent, and it's mostly with regards to providers. Okay? So it's how much risk are providers taking? Because you see in some of these types of plans, physicians are still reimbursed to some degree based upon each service they provide. And some, they're given a capitated payment. Capitated means, no, not decapitated, like take your head off. It means a per member cost. Now, a couple of times this semester, I know I've used the example of a lemonade stand. Okay, so let's think about a capitated fee in terms of you owning a lemonade stand on the sidewalk. If you sold lemonade as a fee for service, then what does that mean? That would be the traditional model of you selling lemonade. That means you went and bought lemonade, sugar, ice, water, you bought a little sand, you bought advertisements, you bought some paint, signs, you bought some pitchers to pour it in, you bought cups. And then you figure out about how much it would take for you to make a profit, and that's what you charge for your glass of lemonade. And let's say you charge $2 per glass of lemonade, and each person that comes, it's $2 per glass of lemonade. That's fee for service. Now, you might have a lemonade stand on the corner, and I may not like the inconvenience of having to pay $2 each time because I don't like to carry cash, and I really, really, really like lemonade. So I come up to you and I say, well, let's make a deal. I will give you $200 right now, and you give me all the lemonade I want the next year. Now, who's bearing the risk under that agreement? The person who's owning the lemonade stand. Because they've already agreed that they're going to take $200 from me. And if I go and have 4 cups of lemonade every day and end up consuming 1,200 cups of lemonade for the year, she loses money. Okay? But she could stand to make a lot of money. I've already paid her the $200. And what if all of a sudden my taste change and I get tired of lemonade after 10 cups? What if I end up going on? What if I get a new job that has me going out of town all the time, and I end up just drinking 10 glasses of lemonade all year? She actually makes more money, but she's bearing the risk. It's not entirely different than investing in the stock market and all that, which I'm not going to get into. Okay, but usually those things that bear the most risk can make you the most money. But you can also stand to lose money. Just like investing, you can take your money and you can go put it in a no risk bearing checking account for like 1% interest, or you can put it all in the stock market, and you can balance for your portfolio by putting it in different stocks or in different funds. Or you can say, I'm going to take $50,000. I have $50,000 to my name, and I'm going to put it all on IBM. You could stand to lose a lot of money. But if IBM stock triples in the next 2 years, you can make a lot more than if you had it in a checking account. Right? That's what we call risk bearing. So you'll see the amount of risk taken on by these different providers varies by the type of plans that we'll go over in just a moment. Then there's physician type. Some plans have small independent practitioners. Some plans have very, very large groups or networks of practitioners within the plan. Okay, so that's another means by which they differ. Another is relationship exclusivity. That's the one you mentioned just a moment ago when I asked the question between HMOs and PPOs. Relationship exclusivity. Oh, I'm sorry. No, that's out-of-network coverage. We didn't go to out-of-network coverage. You're not going to relationship exclusivity. Out-of-network coverage. Okay? So that's from the patient's perspective. Do I have coverage outside of the plan, or do I not? Now, even those that provide you with some sort of coverage outside the plan, you're going to have to pay more. But you might have some coverage outside the plan. With some insurance plans, like some of the strictest HMOs, which I'll go through in just a moment, you have no coverage outside the plan. You can go see a provider outside the plan, you just have to pay for it all yourself. But you have no coverage outside the plan. Okay? That's out-of-network coverage. Relationship exclusivity is from the provider's perspective. That is, does that provider see only patients in that plan, or does that provider see patients from different plans? As we'll see in just a moment when we go through the different types of managed care organizations, some, like with Kaiser, for example, they see Kaiser patients. They don't see anybody else. That's it. Some physicians take people from different plans. Some have Aetna, some have Cigna, some have different plans, and the physicians take people from different plans. And then the level of cost sharing and comprehensiveness of services is another thing by which these plans might differ. So let's take a look at them. HMOs. So that was the original managed care plan. That was the concept was a health maintenance organization. And what does HMO stand for? Remember, I talked about they're supposed to be preventive in nature? Health maintenance organization. So when this bill was first created in 1973 and signed into law by Richard Nixon, the idea was that care was going to be coordinated, and it was going to emphasize people being healthy and preventive care versus just acute care. That was the whole concept behind an HMO. That's why it's called a health maintenance organization. That was the whole concept. And helping to do that would be, helping to do that and to keep costs down would be a referral system. So what costs more, a generalist visit or a specialist visit?
Special.
A specialist visit. Last year, I've mentioned to you my daughter's ulcerative colitis, and we went to her specialist. She goes to a pediatric gastroenterologist. And we were leaving the insurance plan, unfortunately, where she was the physician, and coming into Kaiser. And we were interested, at least somewhat interested, in having my daughter, Brittany, maintain care with this physician. So we asked, said, by the way, how much is one of your office visits, which were typically about 15, 20 minutes? Anybody guess?
1,500.
473.
For 15 minutes of your time.
$473 for a 20-minute visit with her. It was actually, most of them were shorter than 20 minutes. I happened to kind of pal around with her and chat with her a little bit and kind of stretched it out. So it's $473. So, the concept of HMO is that, wait just a minute. Before you go all willy-nilly to a specialist, because in the fee-for-service system, people would just go wherever they want, right? So no, wait. We're going to assign you a PCP, a primary care physician. And that primary care physician is going to determine whether you see a specialist. So to go see a specialist, you need a referral from your PCP. And then, at least in concept, your care actually becomes more contiguous, less fragmented. Because your PCP then has all of your health files, health data, and records of wherever you've been. Because in a fee-for-service system, you could go to this doctor, and then go to this doctor, and then go to this specialist, and go to this specialist. And do they necessarily talk and have each other's records where you've been? No, they don't. So that's the general idea. I'm not saying it always works. I'm not saying it always works well at all. But we'll get to that. But that's the premise of what we're talking about here. The original HMO. I'm just going to literally whisk through these, okay? Because my interest is not you memorizing the difference between all of these things, okay? It's not really the point of the course. The point of the course is for you to kind of just understand generally what's out there, what you're confronted with as a practitioner, and what patients are confronted with, okay? There's all these HMO types. Now, I will say I will talk about the staff model in just a moment. What is the quintessential staff model HMO? That's Kaiser. How many of you are familiar, we all hear the name all the time, how many are familiar with Kaiser or have had Kaiser insurance? Okay, and what does that mean if you have Kaiser?
One-stop shop.
That means to go get care, you go to Kaiser. And you have a Kaiser card. Need lab work? Go to Kaiser. Primary care physician? Go to Kaiser. Specialist? Go to Kaiser. Hospital? Go to Kaiser. Now I know where I reside in Sacramento, there's actually 2 large Kaiser facilities within about 10 minutes of my home. And I was just in the lab last week. It's all like a one-stop shop. Big, giant place. They even have people working the streets to flag people in and out. Enormous facility. That's what we call a staff model. The physicians are actually employed by Kaiser. That's a big difference. It's a big difference. I mean, when you go to a physician that's not in Kaiser, are they an employee of anybody's? They're their own independent contractors, right? they're bearing a lot of risk. They can make tons of money or not that much money at all, because they're their own independent contractors. Just like if you're an independent contractor that did landscaping. If you had a great business, you make a lot of money. If you have a terrible business, you won't make any money. Same thing if you're a provider and an independent contractor. But Kaiser physicians and their other healthcare practitioners are actually employees of Kaiser. They get paid a certain salary. So it doesn't matter whether you show up for your appointment or not. None of these things, they get a salary. Now, just like any employee, if they're good, they can get rewarded. If they stink, they can get fired. But I mean, they're an employee, okay? And that's what we call the most closed type of HMO. That's the most radically different form of healthcare than fee-for-service. That's the most radically different and what we call closed model of healthcare versus fee-for-service, and really what existed before managed care than any other type of care that exists. Okay, that's a closed model, staff model HMO. Typically, and there are others that are smaller, but what we typically think of is Kaiser. These others, as we go down, become a little bit more open. Like in the group and network model, for example, you will see large physician groups. While they're not employees per se, they will often be relationship exclusive and not see patients from outside that particular HMO. So while they're not employees, they're typically on some sort of contract, and they typically have relationship exclusivity, which means they often don't see patients from other plans, okay? And as we go down, like into the IPA and direct contract model, it just becomes more open. Like in IPA and direct contract models, IPA stands for Independent Practice Association. And as we go down that list, we'll see that it shifts more toward the provider, so to speak, and more open. So like an IPA, for example, in an IPA, we're talking about a group of physicians, and they've actually formed their own company to contract with different HMOs. And a direct contract is not even groups, it's just an individual physician who does that. So that's all I want you to understand about those things, okay? Not going to get to this bar graph and compare and contrast all the differences. We know that this closed staff model is a closed quintessential HMO. Group network models become a little bit more open, but often have relationship exclusivity. And IPA and direct contract models is when you have a group or even an individual, as the case in direct contract, physicians who actually go out and contract with different HMOs. So you can see how they differ. Now, PPOs, Preferred Provider Organizations. So in a PPO, you the member, usually have a lot more choice. You have a larger panel of physicians from whom to choose. There is not likely to be relationship exclusivity. In other words, the providers in that plan are likely to see a bunch of different types of patients from all different types of plans. But they might belong to several PPOs. So like a physician's office, a dentist's office, any kind of provider, they might actually belong to several PPOs. And you as a patient then have to, and there's no referral system. There's no primary care physician. There's no referral system. There's no primary care physician. So you can go to see whoever you want as long as they're within the provider network. You can see whoever you want as long as they're in the provider network. And you generally have coverage even if you go outside of the network. You will simply have more cost sharing if you do. Higher copays, deductibles, and so forth if you go outside of the network. Well, you're thinking, well, if I have all this freedom, why wouldn't I choose a PPO? Yeah, they cost more. The premiums for PPOs are higher because HMOs have a way of controlling costs more than PPOs do. So the premiums are higher. And the set of services covered by your HMO could actually be more extensive. Not always, but often. Often the array of services covered by your HMO could be more extensive and at a less amount of cost sharing for you. EPOs are like a hybrid of the two. No primary care physicians, no referrals, but it was already exclusive. What do you think that means? That means no out of coverage. So it's kind of like an HMO, kind of like a PPO. You don't have primary care physicians, but there's no out of network coverage. That's called an EPO, an exclusive provider organization. And what I want you to know is simply this, okay? There are, in fact, still traditional HMOs, various types of HMOs. There's PPOs, there's EPOs. But there's all sorts of plans. And they continue to hybridize. So again, the market is like the market for cereal. Keep going back to that. Hopefully that'll helps resonate. You used to be able to just go to the bathroom flakes and Sweetie Puffs. That was your choices. Sugar or bathroom. Now you have everything in between. And this is the same thing here. I mean, well, I don't want to go to just Kaiser. I want to be able to go wherever I want. And other people are like, well, you know, the PPO is kind of expensive. So now you have everything in between. Not every employer will have everything in between. One employer may offer 5 or 6 plans. This employer may offer 5 or 6 plans. So if you have employer-based insurance, it's going to be limited to a degree. Your options will be limited to a degree by what that employer has. But most employers have several plans, and you'll see the choices line up. And of course, that's the whole problem with the complexity of it all. And my job is to understand this stuff. And yet, have you ever received a packet from an employer of your health plan choices? That real easy to look through? Real easy to decide which plan to pick?
No.
Oh, it's a nightmare, isn't it? It's a complete nightmare. But that's the cost of choice. But it's a nightmare. So you have to sit there and you have to figure out, well, okay, my premium's $300 a month higher for this one. Now, but my copay is higher, my deductible is higher, my coinsurance is higher, and if I go outside the network, it's higher. So, do I think I'm going to me and my family are going to consume $300 worth of extra copays and coinsurances per month by getting the cheaper plan? And am I willing to get referrals and so forth and go through that for a less expensive plan? So that's the decisions that lie before us when selecting health plans that differ by those characteristics. So the health plans differ on those characteristics. Then you have a menu of options before you to pick the plan that you think will be best for you and your family in the upcoming year, based upon plans and offerings that basically differ among these characteristics. That is in a very, very, very broad, oversimplified version of what managed care is. Oh, look, I have some pretty cartoons for you that help explain it all.
Yeah.
Look, see? Woo!
So pretty.
Yay!
So pretty.
Look how nice. Blue, purple, pink, green. But if you look at basically, it characterizes the very, very, very basic differences between those three as just what I told you. See how the EPO is kind of in between the HMO and PPO. Just like the PPO, you don't select a primary care provider. But like the PPO, like the HMO, you have to stay in the network. Oh, more fun. More fun. More fun. Woo. Rating. Supposed to be blue and yellow make green, right? In this case, we have green and yellow that made blue. So they're a little off. So they're very correct in what they put on there, but they weren't very good in terms of of what colors make what color. So green and yellow made blue there somehow. And you'll see again, PPO out of network coverage versus HMO, you have lower premiums. The PPO usually has a very, very large network that may exist your own geographical boundary versus an HMO where it'd be more confined, but then you have lower co-payments, you have a smaller network, and you don't really have coverage outside of that network. Oh. Now in your exam, you're going to have 13 questions just on that.
Sweet.
Right there. No, you have to, come on. You're youths. You're youths. You have to be able to read this stuff. You're youths. Yes.
I can't even read it with my glasses.
I'm not going to even go that much into accountable care organizations because you're going to have subsequent 603 classes, and you can have someone from Covered California coming to talk to you. But you've heard of accountable care organizations, right? That was the premise behind the Affordable Care Act. Well, there's lots of premises behind the Affordable Care Act or Obamacare. But one of them is the formation of these accountable care organizations. Did Dr. Yoshi talk with you at all about accountable care organizations?
Not yet.
I'm hearing some yeses and hearing some no's, so that confuses me.
About ACO.
Did he talk to you at all about accountable care organizations?
No.
Not really?
I think
Okay.
so.
Well, let's just say accountable care organizations are basically still being developed now as we speak. And the whole premise behind the Affordable Care Act was that these different organizations, so like an HMO and a PBM that does prescription insurance, which I'm going to discuss in just a few moments, and say mental health providers and labs and all these different providers would all come together and be a whole accountable care organization. You can almost say that Kaiser is, in essence, already an accountable care organization because they have everything under one roof. So the premise is that these different providers, not that they would become employees, not that they would all unite under one roof and close a lot of facilities down, but that they would contract together to form an accountable care organization. Accountable because now this whole organization, which includes pharmacy, labs, physicians, technicians, hospitals, that they all come together as one accountable care organization, ACO, to meet all the patient's needs, and again, accept a lot of risk in doing so, and provide coordinated, unfragmented care to patients. And the Affordable Care Act was designed in part, of course it's designed to do a lot of other things, but the Affordable Care Act was designed to actually spur the creation of these accountable care organizations. But we haven't really seen that evolution take place. How many of you have heard of the concept a medical home? Medical home, that's a term that's also been around before Obamacare. It was the same kind of principle. A patient would have a medical home. And in the medical home, the patient could get, there were no more carve-outs, okay? Mental health, pharmacy, dentist, vision, everything was under the auspices of a medical home. And so that meant, and that would have to be facilitated, and one that hasn't facilitated a lot because our healthcare system is so fragmented and the technology hasn't really developed. I mean, as much as we have technology developed, you really need sort of these smart cards that would work at the dentist, the eye doctor, the physician, the hospital, everything else. And your medical record would basically have to fit on that card. That's how it would really, really work, to be honest. And the technology is getting there, but it's not quite there yet. Now, I showed this slide last year, and I had a good discussion with the P1 class then, because this is reminiscent to me of Candyland, and they were insistent upon it being Chutes and Ladders, but I don't see Chutes and Ladders, so I think it's Candyland.
I think it's the game of life.
What's that?
It's another game called Life, or the game of life.
No, I think it's Candyland.
Okay, you're right.
So, being the authoritative dictator that I am, I'll ask you, your slide looks like which game? And the answer is Candyland. Because being the authoritative dictator I am, I say it looks like Candyland. How many of you have young children? Okay, so not many of you. See, I have had a child, and I've played lots of Candyland. And when I see this, it reminds me of Candyland. That's why I know better than you what this looks like. If you haven't had a child, and you hadn't played Candyland since you were a child, whereas I played Candyland more recently than you, then I'm a greater authority on the subject.
That was very good.
And as such,
My favorite game.
I say
Yeah.
that this is Candyland. Now take a look at this. It basically just,
No, dude.
again, way too detailed than I'm even interested in. But I thought sometimes I just add these slides, for your benefit, for your edification. You can try to get what you will out of them. It basically shows you sort of the evolution of an accountable care organization and what has to happen. The identification of providers, development, the incorporation of different institutions, adoption of certain rules, assessment, evaluation, and then investment, and then working out contracts with say Medi-Cal or Cover California, things of that nature. So it's just, you know, if you take a look at that, it might help you. And I'm not interested in you understanding more than that from right now, because accountable care organizations, they're there and people talk about them. And if in certain sites that you may be following on Twitter, it might be talking about them a lot. It all depends who you're following. But they really haven't developed yet. But just know that, you know, in principle, this is what they are. This is the concept of a medical home. Accountable care organization is just a more formalized mechanism of defining what a medical home is, and the way of sort of institutionalizing it, if you will, where an accountable care organization would come together, bear risk, and say, and then contract with a carrier or with Cover California, something of that nature. So, looking at a managed care organization, and now from now on, when I say health plan, insurance company, managed care organization, know that I'm basically talking about the same thing. If I say insurance company, if I say health plan, if I say managed care organization, I'm basically talking about the same thing. Something that provides you with medical insurance. So let's look briefly at the finance and budgeting for a managed care organization. So they receive their revenues. And so this is important because I'm about to go over the pharmacy portion of this. And so it's important to understand the basis of this as we talk about how it works with pharmacy and prescription drugs. So they get their revenues, the insurance companies, mostly from premiums and from cost sharings and so forth and so on. Then they pay out their expenses. And if you look at their expenses, they'll break it out into hospital services, physician services, other medical services like respiratory therapists, speech therapists, pathologists, so forth and so on. Chiropractors if they're in the network, and prescription drugs. And prescription drugs take up about what % of the budget? About what? You hear it all the time when you talk about insurance companies and pharma debating each other all the time like they do. It's about 10%. It's about 10% of healthcare dollar is prescription drugs. So they take in their revenues, then they have their expenses, and then they have their own administrative expenses. Because as an insurance company, they have hundreds of people hired themselves. Okay, so they bear a lot of expenses for adjudicating claims and doing everything that they do. Plus, they make a profit as well. The insurance company does. All right, now some are not for profit, like Blue Cross Blue Shield, but they really make a profit. I'm not going to get into all that. So, if you look at the expenses that an insurance company has, and the expenses that it has in terms of paying claims, well, that's just what consumers and patients use, right? That's the medical care that was used. On top of that is the administrative expenses and profit of the insurance company. And that's what we call a loading fee. So the medical care they paid for is simply the medical care they paid for. The loading fee is the administrative expenses of the insurance company running itself plus the profit that it makes. So in other words, that's the cost on top of what it already costs in terms of getting medical care. On top of that, we're paying loading fees by insurance companies, of insurance companies. That is, their administrative expenses plus their profit. And that's called a loading fee. And then when they develop their premiums, in other words, how much they charge employers, they look at their costs, and then on top of that, the loading fee is averaged, is added on to, excuse me, not average, the loading fee is then added on to that. So if Aetna, for example, they'll say, well, okay, we have data that shows on average, we spend $600 a month for every person that exists, and then it costs us $200 a month per person to operate, and we make $100 of profit. Thus, that's $1,000 per person per month. Okay, so that's how the premium is developed. Now, I've already mentioned the whole concept of referrals and so forth that HMOs do. But there's other things that managed care organizations or health plans do to try to keep costs down. Some might argue very futilely because healthcare costs continue to go up and up and up each and every year. But some of these things are what the managed care organizations of the health plans do. I mentioned the referrals, that's done primarily by HMOs. They engage in case management and denials of care. How many of you ever heard of a story where somebody was denied care that they wanted? Okay, that happens a lot. Okay. Granted, given that all the times it happens, sometimes it's probably justified by the insurance company, and sometimes they make the wrong decision in doing so. They try to modify provider behavior by education. You ever heard of counter detailing? Counter meaning opposite. So what's detailing? What do pharmaceutical companies do? What do pharmaceutical companies do with regards to physicians? You heard of a drug rep? What do drug reps do?
Sell the newest drug. Advertise.
They promote a product from their company and often provides explanation.
Yeah, they go around, they visit all the providers, and they say, hey, you know, this is our new drug, and it's better. We have these 3 studies that show that it's superior. You know, the antibiotic kill rate of our competitors is 81%, but ours is 88%. There's a significant difference. There was a study that showed that we have 20% fewer of this particular side effect and this particular side effect of our drug than our competitor's drug, and so forth. And they're going to go and they're going to detail, you call that detail the providers, to try to get them to prescribe their drug. Well, insurance companies engage in what we call counter detailing. And so they not so much send people in person, although they do, some of them do that. They more so send written information. So, you know, they'll say, actually, the most cost-effective drug is this, and this is why we have it on the formulary and not the others. So they try to incentivize providers. They try to educate providers from their perspective on their prescribing behavior and their utilization behavior. They'll also incentivize them. So risk sharing and risk pools. They'll have their network of providers, and they will set a target of utilization and costs for that whole health plan, say for the year. And they'll tell the providers that if you come under this much, we'll actually provide you with a bonus. So they're actually trying to incentivize providers to reduce their utilization with these risk-sharing pools. In other words, you share some of the risk with us. In other words, if you utilize too much services, okay, that might cost you in this or next year's contract. But if you go under that, we'll actually share some of the extra bounty with you. So they're actually bringing them into what we call a risk pool, helping to pool the risk with them. And of course, they also negotiate prices. I mean, as we're about to talk about in pharmacy, they try to get the very, very lowest possible price for prescriptions. They try to get the lowest possible price. So you see, when I went to the physician, and she told me that if I paid cash, it was going to be $473 for my daughter. Now, do you think that's what the insurance company pays? No. So for one, besides the insurance company covering most of the costs for me, but the insurance company is paying less than I do for the same thing. Because the insurance company has negotiated this. And they've negotiated this, well, if you become our provider, if you come into our plan, we're going to guarantee you a certain number of patients. So we're not going to pay you $473. We're going to pay you $320. So they actually pay less than I would if I would go. Okay? It's not the only place where price discrimination occurs. Get on a plane tomorrow with 100 people. There's going to be 100 different prices that people pay to sit in that plane. It's based upon a whole number of factors. When you bought it and so forth. Do you have airline miles? Are you a gold member? All this kind of stuff. Now, how does this interact with pharmacy? We'll start talking about that, and then we'll take a break. Managed care actually, before I get into the pharmacy benefit, managed care actually, there's a lot of utilization management efforts, as we'll go through, to try to keep prescription drug costs down. There's at least in principle a design by managed care organizations and PBMs, pharmacy benefits managers, something I'll go through in just a minute, to try to coordinate your care and coordinate your pharmacy benefit. From your perspective, there's actually, and we've had a number of graduates here at Toro the last few years that have actually gone on straight to jobs and working for the PBM industry and so forth. And some of those jobs are actually a little bit more clinical than you might think they are. You might think, oh, I'm just wearing a suit, I'm not really providing patient care. But you may be a person who's actually in charge of deciding what drugs are on a formulary, and then thus you're charged with looking at pharmacoeconomic data, the latest clinical studies, and so forth and so on, and actually making population-based decisions where you're not providing individual care. You're actually you're helping to make decisions that affect thousands, tens, hundreds, even millions of people who are in a particular network. Okay? So the job, in fact, may be more clinical in a certain way, even though you're not providing direct patient care. So as I mentioned, the pharmacy benefit is, let's see, I'm going to go back to this. I want to stay on the pharmacy benefit. So as I've said, it's often a carve-out. It's often a carve-out. And that's why we need, well, I don't know why we need, but that's why we have in the market PBMs, pharmacy benefits managers. Who can tell me what a PBM is? Da, 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 da. Da, 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 da. Da, 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 da. Da.
Wasn't it? You just said.
Pretty much they negotiate, right?
You've never heard a pharmacist say that damn PBM?
All the time.
All the time. So when they say that damn PBM, what are they talking about?
How PBMs try to reimburse them for less amount that they typically do.
Okay, so what's a PBM?
Kind of like a negotiator, right? Sort of between the patient and the
They
pharmacist.
negotiate and do a lot of other things. Anybody else? What's a damn PBM? What's a damn PBM? Well, remember? So believe it or not, all this ties together. My lectures actually are coherent. You might not think so. They actually are coherent. Remember I'm talking about prescription drugs not really being an insurable hazard? Because they're really not. It's something that, do people get prescription drugs or go to the hospital more often? They get prescription drugs more often. Is the size of the claim bigger with a hospital or with a prescription drug? Prescription drug. So this is very different, isn't it? So you have, rather than something that's unexpected, like a hospital visit, that's hopefully for most quite rare, but huge and unexpected, versus something that is almost known, because once you're diagnosed with diabetes, for example, it is known that you're going to take some combination of metformin and insulin or what have you for the rest of your life. So you have lots and lots and lots and lots and lots of claims that are all smaller versus hospital claims. So companies arose out of this, knowing the difference between pharmacy and, say, hospital and others, called pharmacy benefits managers. So the managed care organization carves out the pharmacy benefit, and then they contract that to the PBM. So the PBM handles the pharmacy benefit, because the PBM specializes in the pharmacy benefit. The PBM handles infinitely more claims with prescription drugs than hospital visits, with each of those smaller and requiring basically a different set of expertise and know-how than handling the rest of the medical benefit. So the managed care plan, now we're not talking about Kaiser, because Kaiser does it all. But like Aetna, for example, if you have insurance through an insurance company, they then contract out the pharmacy benefit with a PBM. And that's just a depiction of the relationship that exists there. The patient has insurance with their employer. Let's see if this thing has a, does this thing have a little laser? Does it? Yeah, so the patient has insurance through their employer who sponsors their plan, okay? But then the plan contracts with the PBM. The PBM has the contract with the pharmacy. When you as a patient, you go to the pharmacy. And as a patient, you get a prescription at the pharmacy. And the pharmacy, as soon as you hit, now as a pharmacist, or now as pharmacy interns, as soon as you hit send, and you're all done with Mrs. Jones' prescriptions, then online, in real time, digitally, that is sent to the PBM. So Mrs. Jones comes and gets an antibiotic and her monthly Paxil. You fill those two prescriptions, and as soon as you press send, all done, there's an electronic communication that's sent to the PBM, and the PBM then is notified electronically in milliseconds that you just filled the two prescriptions for Mrs. Jones for her antibiotic and her Paxil. So the PBM then immediately has an account of the fact that it has, in essence, approved the prescriptions for Mrs. Jones's antibiotics and Paxil. And thus, after a month, for example, of getting all of these claims from all the Mrs. Joneses from that pharmacy, they're then going to cut a check and pay the pharmacy. And the pharmacy, of course, purchases its drugs from wholesalers, sometimes directly from manufacturers and distributors who get their drugs from manufacturers. So that's how this all works. Insurance contracts with PBM. PBM is online with the pharmacy. And sometimes when you try to hit send, what happens? It might be denied, okay, because they're online real time. So if it's approved, the PBM, okay, says, all right, well, that's one we owe the pharmacy. Otherwise, it might get rejected, and the pharmacy technician might have to call the PBM. All right, then the pharmacy purchases its drugs from a wholesaler who gets their drugs from the manufacturer. All right, so with that, let's take a break. 9.2 minutes.
So what he was saying, so ACO, he said we're gonna learn later on because I kind of didn't understand what he was talking about now.
I'll get coffee.
Community rating is when everybody is charged.
Yeah, they're still there.
Saw it coming back.
Yeah. Priorities or money? Yeah. Those kind of like feels like right after blocks.
But then when we found out our grades,
Good for you, Sam. Stay focused. In priority. Did you try out Mahjong on Sunday?
Dude, it's only dinner 5 to 9.
Oh, wait, really?
I was gonna go for lunch, yeah, because I had to go to like a wedding reception, so I couldn't go at night.
Oh, shit.
Yeah. But like, one, it's only dinner 5 to 9.
I think it was like soft opening.
I have no idea. I didn't try to buy it. They shut it down.
Really? It should be open for lunch. Or like they open up like
Because I
2
looked
or
on
3.
Yelp and it said it's only 5 to 9.
On Sundays?
Like every day, 5 to 9. Like look at the hours. And I think they're closed one day, like Tuesday.
Yeah. Okay, yeah. What exam? Fuck it. I'll just keep her and learn everything. I don't care if it's a she or a he. It could be a he, she for all
I was in a
Where's Jenny?
She took a nap. Yeah.
Oh, you're just
Like I remember the other day I was like, I know. Oh yeah, he did.
Really?
Yeah.
See, I wasn't there, so I didn't know.
I saw him snap. I went to SoCal.
Oh no! Okay, I thought you said your grandparents
Shiva?
brought a dog over or something.
I follow one on Instagram. I follow on Shiva. Yeah, Shiva. Your dog is Oh yeah, cause I don't know what that is. I was thinking more of like Kuro Tonkatsu ramen. I think with the black sauce. Yeah. Oh yeah. See, you guys sit behind me. You can either pay attention or you can't pay attention. If I see you guys next time, I'll be like, oops. Yeah. Oh man, I'm just helping you guys out. It's like, okay. It's alright. I'm gonna make sure you weren't doing anything. That's good. A plus, 100%. Why not? Oh really? Well, you told me that actually.
Yeah, I showed you the email.
We're all gonna make it. We got this, Ryan. Track 4 is the only. Average is good.
Nice haircut, man.
Thank you. It was getting too long, so I decided to cut it.
Yeah. So what did he mean by counter detailing? Because he was saying like pharmacy reps, they want like their main goals to go to providers and say, we want you to take our drug because.
So that was the providers.
To
To the providers.
Yeah, to the providers, and then what's counter detailing?
Counter detailing is when the insurance companies will go up to the doctor and say, hey, you shouldn't get this drug because it's actually more expensive and we have a better drug that does the same thing.
So they're like competing with the farm reps.
Pretty much.
Okay.
They'll usually argue with strategies for cost effectiveness.
Okay. Okay. So, who's the insurance companies are the counter detailers? Okay, so they're the ones saying like we're cheaper, we're more cost efficient, whatnot. But then the pharmacy reps are saying, oh no, like our drug will work wonders, more magical. Yeah, it's more expensive, but like look at this, it's turning purple. Okay. Okay. Alright.
3 weeks ago or so,
I'm trying to get the hang of this
they
stuff.
had like a slide on there. It's actually on Facebook too.
And then ACO is kind of like also a one-stop shop kind of idea, or they're trying like healthcare is trying to go towards ACO. Yeah. Okay. What? Kaiser's not that technically.
Just kidding.
It
We
stands
talked
for.
about a bill that tried to spur the growth of ACOs, but it's
So
never
what I'm
did.
thinking
Oh, okay.
is that we're gonna ask us, we're gonna give us like a posing question.
Emergency integrated
We're gonna
center.
ask us how to convert this to a open question. It's gonna be a free response.
Never mind, I'm not.
That's all. There's gonna be like only a couple of those. Yeah, it's very normal choice. So is that I know 30 for the first one. 10%. Good luck. One of.
Well, here's a good definition of it. It's the healthcare organization that tries to so it's supposed to improve patient outcomes. Because you know how, like, just because our current market is based off of profit, it doesn't necessarily know benefit.
Right. It just means that the providers are making more money.
Yeah. So now they're gonna try to change that with ACOs. So they're gonna tie in. They're gonna say if the patient comes out healthily, then we'll pay you more.
It's like oh, you cured a patient, here's more money.
Yeah. But if the patient comes back, that's where you get penalized, right?
Because you didn't cure them or you didn't like take care of them as well. Okay. I wonder how we're going to be tested on Friday.
Yeah, me too. We haven't talked about ACOs that much. This one, the young thing might ask you, like, what's the purpose of the government behavior? Or
I'm
how did it
thinking
start?
Yeah, because I think of pharmacy benefit managers as like kind of insurance. And then it makes sense how he was saying, like, for the pharmacist, if you want to approve a drug, it goes through insurance, it actually goes to pharmacy benefit managers. I thought it just goes to insurance, but
Yeah, me too.
I guess it goes to pharmacy benefit managers.
I know they never reimburse them for the full amount. Or if the
Yeah.
market changes,
Yeah.
since the drug goes up, it takes time for that price to reflect.
Right, so like one patient can pay $10 copay, and then like it actually goes down for that same insurance for another patient. They pay $5 the week after. Yeah. Okay. Ah.
Do you farm too? Or-
I was, but I really hated insurance, and it was pretty bad at drop off. Like, I mean, I was that person that kept coming back to the pharmacist and saying, like, yeah, it's not going through insurance. What do I do? Yeah, I hated. I've only made like a handful of insurance calls in the 2 years that I worked because I started as a clerk.
It wasn't fun at all.
And then like my pharmacists, they already knew like the codes, right? Or they already knew like the shorthand, so they would just like take the computer and be like, oh, here you go.
So we'll resume with this
Yeah.
fantastic discussion of pharmacy benefits managers. Mr. Williams, greetings. I like your tie today. That's what I'm talking about. That's the man right there. I promoted Deshaun from, what was that material you had? Rayon? No, the polyester was actually the good one. Yeah. So we're moving him from rayon to silk ties. So we're making some progress. Don't y'all like this? Come on, give Deshaun a hand for his tie today. See, you get the love. You get the love when you wear a silk tie.
I hope that's silk.
You get the love.
Is that silk you got on for that?
Seriously? I mean, come on. Is my tie silk? Come on, that's silk. That's good. That's funny stuff. Is my tie silk? It's like asking if I'm hungry. All right. Where's my thing? There it is. This is just a, you ever notice I don't teach from graphical stuff. I actually think they're funny. But I know some people are quote unquote visual learners. So I throw in a slide
Don't hate.
to make it all cool. Hey, I can't control that. So I throw in a slide to make it all cool for you visual learners. It basically, it adds a little bit of color to this. There's really no difference in what it says. So for those of you who like colors, and a little people, and a little green thing with windows that says it's a manufacturer, then look at that. Okay, so I've explained PBMs and why they exist. So what do they do? Well, just like a managed care organization recruits providers or physicians to be in the network, PBMs recruit pharmacies to be in the pharmacy network. And they develop a pharmacy network. So a pharmacy can be a member of that PBM or not, and be in the network of pharmacies or not. So everything we've just been talking about managed care, just extrapolate that here to pharmacy. Except instead of the managed care organization, now we're talking about a PBM. So the PBM develops a network of pharmacies. You've probably both seen as a patient and worked as an intern and seen how, oh, now we're accepting so-and-so plan. We're no longer accepting so-and-so plan. Have you seen or heard that before? Yes? Okay. So that is the pharmacy and or the PBM's decision to either have this pharmacy come into the plan, or if they're already in the plan for whatever reason, economic differences, disagreements, whatever, backing out of that plan. Okay? So they recruit pharmacists. They really design, PBMs design the prescription drug coverage for the patient. In other words, what's going to be covered? What's going to be on the formulary? What's going to be, say, Tier 1, Tier 2, Tier 3? How many are familiar with those concepts? Everybody? No? Okay. So, if you as a patient go to get a drug, you will in all likelihood experience different tiers that the drug belongs in. It may be 2, more often than not it's 3 or 4 tiers. And a tier will correspond to the amount of copay that you're responsible for. Because they are encouraging you and your physician to utilize what? The cheapest, which are normally generics. So more often than not, a generic is going to be in Tier 1 and will have the lowest copay. Then, let's just say for the example of a 3-tier plan. And of course, they get more complicated than that. Tier 2 might be a preferred brand. And Tier 3 will be a non-preferred brand. And each of those represent a substantially higher amount of copay that you would pay as a patient. And so, how that works, what's on the formulary, what's covered, whether it's on Tier 1, Tier 2, or Tier 3, whether there's going to be prior auths, whether there's going to be the disease management and things of that nature, is determined by the PBM. Now, ultimately, it gets signed off by the PBM's clients. PBM's clients are whom?
The insurance companies?
The insurance companies and the employers. Okay, so those are the clients. So ultimately, they'll be signed off by the employer, ultimately they'll be signed off by the client. But you can, Turo, for example, besides being an educational institution, is also an employer. They employ me. Okay? So, at some point, Turo has to sign off on what Kaiser says it's going to cover as prescription drugs. Turo has to approve it. But is someone from Turo going to sit there and actually design the plan? No. Someone, a specialist from a PBM is going to do that, and Turo has to just simply sign off on it and approve it. Maybe make some changes. So for example, a Catholic university, a Catholic hospital, do they generally provide coverage for birth control pills?
Nope.
They won't. Okay, because that goes against the whole premise of Catholicism. So they're not going to provide coverage for that. So the PBM may design a whole plan and say the employer, the Catholic university, the Catholic hospital, or whatever, might look at that and say, well, that's good, except we're not covering that. The PBM says, okay, well, we'll make that change. Okay, so the PBM will design the plan, employer and the insurance company will ultimately approve it or make changes. Okay? And naturally, even though the PBM designs the plan, naturally the employer is going to have some input. So besides the very obvious example I gave you of a Catholic institution not supporting abortifacients or things like that, there's going to be some other discussions. Different employers might differ to the extent that they might cover lifestyle drugs, might cover erectile dysfunction drugs, and things of that nature. Different plans are going to have different takes as to how much of that they're going to want to cover. But in essence, the plan is designed by the PBM. Okay? And they're going to conduct drug utilization review. Now, DUR, and we're soon going to compare and contrast DUR, DUE, and DRR, which we'll do in a little while. Drug utilization review, the PBM will go in and they'll also conduct audits They'll look at, for example, hey, it seems like we spent 20% more this past year than the previous year on protein pump inhibitors. So let's conduct some drug utilization review on protein pump inhibitors. Let's try to figure out why we spent so much more on protein pump inhibitors this year than we did the previous year. Was it a handful of doctors that are doing all the prescribing? Or was it sort of diffuse and spread out throughout? Was there, or is it GPs that are doing it? Or is it specialists that are doing it? And if they're doing it, are they doing it under good situations? Or are they actually prescribing it when it's contraindicated? So they're gonna do an audit and a drug utilization review of, for example, of the protein pump inhibitors, which is just one of maybe 8 billion examples I could use. Okay, that's a drug utilization review. They'll go back and look 1 year, even several years worth of data. And they'll find out if certain drugs are being used inappropriately by too many people, try to get to the root cause of it. They'll see if they're spending too much on something, try to nip that in the bud, and do that through provider education. Or maybe they'll say, you know what? And I'm just using protein pump inhibitors as an example. So, you know what? Our spending on protein pump inhibitors last year got out of control. And from the drug utilization review we conducted, it looks like to us that in almost 40% of the occasions, the patient really didn't need a protein pump inhibitor. Thus, we're going to take them from tier 2 to tier 3. That's kind of how it works. That's their decision-making processes. Or we're going to put it on prior authorization. Now, now you've heard the term prior auths. So you heard pharmacists say damn prior auths. So what's a damn prior auth?
Approval from the provider.
Da-da-da-da-da-da. Yes?
You have to contact the doctor for them to write an explanation why they should cover that medication.
Right. It's going to be covered only conditionally. It's going to be covered only conditionally. And usually that's reserved for drugs that are more expensive, obviously. And there may be different reasons why something is put on prior auth. Maybe, for example, they conducted a DUR and saw that a drug was being utilized too much. Maybe it was being utilized under situations where it was contraindicated. Maybe they're just spending too much on the drug. You might have a drug, for example, that has multiple indications, which is very common, say, for like an ARB, okay? Some of the newest class of antihypertensives. ARBs, what are they, angiotensin blocking, I don't know, what does that stand for?
I think it's angiotensin. Angiotensin.
Angiotensin receptor blockers, okay. So ARBs represent a clinical advance over ACE inhibitors, for example, okay? And so ARBs might be, and ARBs don't have quite the side effect profile that ACE inhibitors do. But ARBs might be several times more expensive than an ACE inhibitor, particularly some that have been ACE inhibitors that have been in the market for a long, long time that have generics like lisinopril and captopril and so forth and so on. Now, an ARB might have an indication for hypertension, severe hypertension, but also have indications for other types of heart disease, like atrial fib or pheochromocytoma or something like that, or very, very resistant severe hypertension. So the insurance company may say, okay, we're going to cover this ARB, but have it on prior auth. That means any person can't just come and get a prescription for ARB, because we are not, if the physician wrote the ARB merely for hypertension, we're going to say no. We're going to say put that patient on a beta blocker, a generic ACE inhibitor, or a generic calcium channel blocker. We're not going to pay for the ARB. So the prescriber or the pharmacy, if they have the information, would have to call and say, hey, this drug's on prior auth, but you need to know that this is actually being used for a patient that has resistance toward other therapies that have been utilized, and also has pheochromocytoma, and so forth and so on, so it needs to be covered. And the insurance company will make a decision as to whether they're going to cover it or not. Okay, so that's going to prior authorization part. So the PBM does all of this stuff. Okay. Now, so what drugs does a PBM put onto its formulary? And even beyond what it puts on its formulary, what sort of bases does it use to put a drug, say, on tier 1, tier 2, tier 3, prior auth, no prior auth, what have you? Well, they look at all of these things. Effectiveness and efficacy comes first. The drug's safety profile, the drug's costs, outcomes that have been written on in the peer-reviewed literature about that drug, impact on other healthcare costs. So one drug might be a little bit more expensive than another one. So drug A might be a little bit more expensive than drug B. But what if drug B has these awful side effects that ends up putting people going to the doctor or having to be lab valued and monitored and so forth and so on? It may end up costing more than drug A, right? In total cost. So in that case, drug A, while the acquisition cost is higher, the total cost is actually less. So they may choose to cover drug A, even though it has a higher wholesale cost than drug B. Patient adherence, again, some drugs have better, patient adherence is very low and very problematic, as many of you have written on your Twitter accounts. But some drugs have a better adherence rate than others. Some drugs are more convenient to take. They only can be taken once a day versus 3 times a day. Some drugs don't have nasty side effects that others do, so the patient's more likely to be adherent to it. Some drugs come in big old giant horse pills that people don't want to take. Whatever the reason, and there's lots of them. Some medications are more patient-friendly, if you will. Patients are more likely to be adherent to it. The ability to be used in broad populations. Some drugs, for example, can be used, they might be effective, but they may be not approved for use in children. They may be not approved for use in older patients. They may be not approved for use in patients with renal problems. They may be not approved for use with patients with liver problems. They may be contraindicated with a whole bunch of other different drugs that often patients might be on. So all that's a consideration in terms of its ability to be used in a broad population. If a drug can be used to treat more than one disease, that speaks very favorably of it. Sometimes a drug is the only drug that can cover what we might call a niche or a rare disease. Okay? Can the drug be easily controlled or restricted if it needs to be? All these factors, the pharmacokinetic, the bioavailability of the drug, its relationship to current prescribing habits, its use in published guidelines. I mean, if the American Diabetes Association comes out with new guidelines that says, okay, this is what we recommend to treat diabetics, stage 1, stage 2, stage 3, and stage 4. Okay? If a drug is up on there in stage 1 or stage 2 is recommended by the American Diabetes Association, then it's likely to get covered. If it's not, if it's stage 4, or if the ADA guidelines say this is only for a recalcitrant or for rare cases, then it's less likely to get covered or likely to be put on prior auth or in tier 3. Okay? Patient demand, physician demand. Sometimes physicians say, I know the literature says this, and I know the American Diabetes Association says this, but I can tell you what I have seen in my practice. Now, one physician saying that is going to be meaningless. But if, say, dozens of physicians, all within a plan, all say this, and our experience suggests this, then the insurance company might start listening. Okay? The role of direct-to-consumer advertising, that's what DTCA stands for. It has a role, and sometimes patients and even employers will start demanding the drug based upon, in part, marketing. But it probably plays a much smaller part in all of this than we typically think. So, what the PBMs do, okay, is try to reduce costs with the plan design, with the DUR, and the plan design then is the formulary, which is what I just went through, and what the factors are that go into what's put on the formulary. In addition to that, all right, they conduct DUR as I suggested, and that's the formal steps of a DUR. But I basically told you that. I mean, they delineate the scope, they identify which drugs they're going to monitor, they're going to collect data, and they'll take action, which is basically what I just explained in more informal words just a few moments ago. They will use mail order because mail order is less expensive. So they will try to get patients to use mail order. For example, you as a patient, and I even have this from Kaiser, I could actually get my drugs cheaper and I can get 90-day supply if I agree to mail order versus going to pick them up at the pharmacy. I prefer going to pick them up at the pharmacy. Now, if the costs were hugely different, maybe I would change my mind. But if it's $10 for 30 versus $15 for 90, I'm gonna go pick my prescriptions up. That's just the way I prefer it. But you have that choice. They'll incentivize using generics. They'll even incentivize therapeutic interchange, where a drug of a completely different class might be used, and that has to be approved by the physician, of course. As I've talked about the tiered cost sharing. Here's something, and some of you wrote about this on your Twitter things about insurance, is negotiated discounts and rebates. And this is what a lot of people don't know. Because when they hear a drug costs X or Y or Z, they think, oh, that's how much it costs. No. That's the price tag. It's like when you go buy a car, do you pay full price? You're an idiot if you do. Sorry if you've been an idiot. I'll call you an idiot, but an idiot if you do. You negotiate. Well, similarly, not quite the same thing. A pharmaceutical manufacturer will tell a very, very large PBM, for example, like Express Scripts. You put our drug on the formulary versus the competitor, we're actually going to give you a rebate of 40% of that drug cost. So you put our drug on the formulary, and it sells, say, 1 million units in the course of the year, we're actually going to discount that drug to you for 40% and give you a rebate. Now, who keeps the rebate? The insurance company. Does the patient see the rebate? No. The insurance company sees the rebate. In fact, a few of you wrote about that on Twitter, and if you follow, and you'll see a lot on that. If you actually, I'll tell you a good organization to follow is the California Patient Access to Treatment, CPAT. CPAT. Now, CPAT is aligned with. They're not aligned. They're friends with pharma. So they put a sort of a pro forma spin on things. I'll admit that. But they really expose a lot with the drug companies, and I try to educate people as to, sometimes where the cost of drugs is really going, and a lot of it is actually being eaten up by insurance companies and not just pharma. Like a lot of you wrote about EpiPens and so forth, and if I have time today, we're going to go over that. So, the PBM, having said all that, signs an agreement with each pharmacy that's in the network. Okay? It's called a participating pharmacy agreement. An individual independent pharmacy may have several of these participating pharmacy agreements, or a chain like CVS or Rite Aid is going to enter as a whole, okay, with the PBM. And it'll state what's on the formulary, and how do we determine eligibility, which is usually a patient identification card of some sort. It's going to determine audit procedures, how often the pharmacy gets paid for their claims that they're filling for Mrs. Jones each and every day. And then they're going to discuss the reimbursement of pharmacies for dispensing prescriptions. Okay, that's a big one. Now, you'll get more of this, I believe, in a subsequent Track 3 class. But let's talk about this to get a general understanding of how this works. Okay? So, when a pharmacy, so when you hit send, as I said a moment ago, when you hit send, and the PBM has approved that prescription, and it's going through, you've then dispensed those 2 prescriptions for Mrs. Jones. The PBM now has an account that shows you've dispensed 2 prescriptions to Mrs. Jones and that they owe you money. Because you have just given product to Mrs. Jones and all you've accepted perhaps is a small copay and you haven't received the rest of the money. So the PBM owes you the rest of the money. So, how do you get paid as a pharmacy? So there's 2 components. There's the drug cost and the professional dispensing fee. So each time you send a prescription, there's the drug cost and the professional dispensing fee. Now, determining drug costs, though, that's not so easy. Because each and every time a pharmacy purchases, say, a bottle of 100 whatevers, or 1,000 of 100 forevers, of whatever, is it paying the same cost? It might pay a different amount each and every day, depending on what wholesaler they got it from, whether they had to short order it and were short and had to be rushed in, whether they bought several bottles of 1,000 or only 1 or 2 bottles of 100. So how is the PBM supposed to know what you paid for that drug? They don't know exactly. They have an idea of what you paid, but they don't know exactly, because you could have purchased 1,000 Captopril tablets on Monday at a certain price, and then another 1,000 Captoprils the next week at a completely different price. So, what do you get paid for having dispensed the Captopril? Well, each drug has an AWP, an average wholesale price. Each drug has an AWP. That's an average wholesale price. Again, going back to my example, it's sort of like the sticker price on a car. No pharmacy pays that much. Pharmacies are going to pay less based upon volume discounts, based upon their relationship with the wholesaler, all sorts of things. The pharmacy always pays less than the AWP. So, keeping with that, how much does a pharmacy get reimbursed? Well, the contract is going to vary. And that's what the pharmacy has to deal with in determining whether they're going to accept a contract and belong to this network in a plan or not. So the term is going to be something like AWP minus 17%. Knowing that pharmacies always pay less than AWP. But sometimes they pay 10% less than AWP. Sometimes they pay 20% less. Sometimes they pay 25% less. But to make it all square and easy, the term that will be offered by the PBM to the pharmacy for the ingredient costs will be AWP minus a certain percent. I know your slide doesn't have the minus percent. That was your new slides in Blackboard have it. So it's going to be like AWP minus 17%. So that's the ingredient cost. And then $1.75 for a professional dispensing fee. So you dispense 30 captoprils to Mrs. Jones. And you've signed this agreement. They're going to pay you the cost of AWP minus 17% of those 30 captopril tablets, plus $1.75 for you having processed and dispensed that prescription as a professional service / dispensing fee. And that's how much you get paid. Everybody follow that? I'm seeing some nods, and I'm also seeing some. So the pharmacy is going to get, when they dispense captopril, there's two parts of the cost. The cost of the drug and the pharmacy's work for processing the prescription. So the pharmacy's cost is based on AWP. The pharmacy always pays less than AWP. The PBM knows that. So they will offer terms. And this is an example, AWP minus 17%. See, the pharmacy might negotiate AWP minus 16%. And the PBM may say, no, we're actually giving you a break already. It's more like 18% that we show that you pay. So we're actually giving you a break. And that's part of the negotiation. But that's typically what it will look like. AWP minus a certain percent, for example, 17, is pretty typical. Yes?
Is the professional dispensing fee negotiated too, or is that?
That's also negotiated. Okay? So that AWP minus the X percent is the cost of the ingredient. Then you have the professional dispensing fee, and that's your plus 175. Now let me talk about the case of generics, and then we're going to have you kind of put your thinking cap on as a potential pharmacy owner. Okay? So MAC is for multi-source products that have generics. MAC stands for maximum allowable cost. MAC stands for maximum allowable cost. Now, I gave you the example of a moment ago of a pharmacy purchasing a brand name drug that could be different from one day to the next. But it's especially more widely varying when it comes to generics. Because generics might have several manufacturers. And if you think they all charge the same, you're wrong. Some generic manufacturers on a certain day may charge the pharmacy $47 for 1,000 captoprils. This other one would charge just $20. That's a twofold difference. So, when it comes to we call that multi-source. Okay, that means generics. That means they could get the drug from potentially more than one manufacturer. Okay, they will be assigned a MAC. And MACs are published by a company called First Data Bank. And we're not going to get into that. Okay, but drugs have different MAC costs. So they will assign, knowing, for example, that a pharmacy could potentially buy captopril. Does everybody know what captopril is? I keep using captopril as an example because it fits. Does everybody know what captopril is? It's an ACE inhibitor. It's one of the older ACE inhibitors. It's antihypertensive. So I'm just using it as an example. Its mechanism of action and what it is meaningless at this point. So it's a generic It's a generic ACE inhibitor that's been around for a long time. It's manufactured by several companies at least. So knowing, say, there might be 10 different suppliers of captopril, and they range from the least expensive to the most expensive, the PBM is going to look at that and say, you know what, these are the 10 different prices that you might get for captopril. We're going to select the median price, or we're going to select the lowest plus 20%, or the highest minus 10%, whatever it is. That's going to be the MAC. So for captopril, there's going to be a MAC. So it's not going to matter in terms of the contract how much you paid for the captopril. The MAC says this is how much you are going to get paid. Now, since PBMs would prefer that you dispense a generic, the dispensing fee will often actually be higher. So you have the ingredient cost, which for single source is AWP minus a certain percent. For multi-source, it's MAC. Okay? Now, that's on that left side. On the right side, you have the professional dispensing fee, which will often, not always, often be higher for generics as a way to incentivize the pharmacy to dispense generics. And a typical, this is not set in stone because these are all things negotiated, but a typical arrangement might be AWP minus 17% plus $1.75 on brands, and MAC plus $2.50 on multi-source. That's not set in stone, but those would be relatively typical in today's environment. So you own Newtown Pharmacy. What do you need to know? Whether you're going to accept this contract or not, what do you need to know?
How much drugs it costs you to purchase?
What's that?
How much drugs it costs you to purchase what's coming in, and how much they're willing to pay?
Well, this is how much they're willing to pay.
Well, the MAC and the AWP.
So what do you need to know?
How much the drugs cost you?
Right, so what's been your purchasing habits? What's been your purchasing habits? And how much have you been able to buy the drug for? Have you been able to buy the drug from a supplier, a manufacturer that you're happy with, that is less than, at the very least equal to, if not less than the cost of AWP minus 70%? In other words, are you able to get that drug? You have to know in your history of operating, have you been able to get most drugs at AWP, say, minus 20%? If you have, that's a favorable contractor. If you haven't been able to get drugs for cheaper than AWP minus 15%, this is not a very favorable contractor. And then on the dispensing side, how much does it cost you to dispense a prescription? How do you figure that out? How do you figure that out?
Time it takes to fill a prescription.
That's right. You've got to do some serious accounting. You better know that as a pharmacist, or you better hire an accountant. Okay, say I'm open 12 hours a day on Monday through Saturday and 9 hours a day on Sunday. I employ X number of pharmacists and X number of technicians working a certain X number of hours, and I pay them this amount of salary. So that's how much labor expense I have. Notwithstanding that I also pay their medical benefits, I also pay their vacation, I also pay this and that and the other, and I pay Medicare insurance tax, and so I pay all that. Then I don't own the building, I rent the building. So how much do I pay in rent? How much are my utilities? How much do I pay in vials, computers, supplies, and other things? So then I can figure out how much it costs me to run my pharmacy for an hour. Then I can determine, and on average, that it takes me 2 minutes to fill a prescription. Then I can determine how much it costs me to run my pharmacy for 1 minute. It takes 2 minutes to fill this prescription. Does it cost me more or less than $1.75 and or $2.50 to fill a prescription? Those are the things you have to know. Otherwise, how are you going to know whether to accept these terms? You'd be making a very blind decision if you didn't know these things, would you? You could potentially accept an agreement where you're losing money every time you fill a prescription. So you better know these things. You also better know what the industry average is. So maybe yours is higher than everybody else's. Maybe Newtown, for some reason or other, is running an inefficient operation. That's what you learn more in your management classes and subsequent track 3 courses. You learn to look at an NCPA digest, for example, that has industry averages on how much it costs to fill a prescription. And if the average industry cost, say, is $1.79 and yours is $1.98, then why? Are you employing too many people? Are you covering too many hours? Or is your machinery and equipment not up to date? Can you make investments or divest that would improve the efficiency of your business? You'll actually get more into that. So this is a health system class, not a management class. In a management class, we'd actually spend several hours just on this. This is just a little preview for what you would get in an actual management class. Since this is a health systems course, I'm just trying to give you a general understanding of how this all works. Anybody can name any PBMs currently? So I talk about PBMs and you hear pharmacists say those damn PBMs. What are some PBMs? CVS Caremark. That's actually the second largest one in the country. Or the largest one be. It's like Family Feud. Express Scripts. Express Scripts, CVS Caremark, Optum. Those are some of the largest PBMs. Cigna, of course, is also a health insurance company. Express Scripts, Optum, Cigna, CVS Caremark. Those are some of the largest PBMs. And who do you think owns CVS Caremark?
CVS Health.
Yes. So PBMs can be owned. Some PBMs are actually owned by managed care organizations. Some have actually been developed and owned by chain pharmacies to gain leverage against other PBMs and other pharmacy competitors. So you have some that are owned by independent ownership, some owned by different corporations, some actually owned by managed care organizations, some actually owned by chain pharmacies. Now, to say they're owned by CVS is true, but obviously CVS Caremark is its own company that's a spin-off from CVS. It's not actually owned by CVS. It's a spin-off side business of the larger CVS trademark. Just a little bit about this stuff here. Pharmacy performance measurement. There's a lot of talk, and there are some pharmacies that are actually put on report cards. And so report cards, oh goodness gracious, I haven't had a report card since I was in high school. Well, pharmacies are put on report cards, and the PBM will actually monitor of that pharmacy, you know, the extent to which they engage in generic substitution, the extent to which they engage in therapeutic substitution, patient adherence data, because that could all be figured out. Now, they don't know if a patient for sure is taking or not taking a medication, but if a patient's on, say, a medication that you take 1 tablet per day, and they're coming every 45 days to get their refill, are they being completely adherent? Probably not. Okay? So they will do this stuff, and they'll actually occasionally conduct a patient satisfaction survey. They'll actually send out, say, a random sample of surveys to say 5,000 out of the 100,000 covered members, and ask them their satisfaction with CVS or their satisfaction with Rite Aid and so forth and so on. And you'll actually get a report from the PBM as a pharmacy on how you're doing. So I'm going to go back and cover a couple of things that I missed on this, but I wanted to see before I did that if everybody has now a firm handle, or at least firm as can be now, on the whole process of prescription drugs, PBMs, and how that works. Questions? How does that seem to you? What are your thoughts and comments as you hear about how that works? No thoughts?
Not very patient-centered.
Not very patient-centered. Okay, how so?
Looking at this is just, you want to build more. That's what I mean, instead of being more focused on reviewing the medication list. It's just, the more you fill, the more you get paid. You charge them for more and maybe.
That's right, and it's generally, do you think, what's profit margin? Now, not profit, what's profit margin? When somebody says they're operating on a high profit margin, what does that mean?
The amount of money you gain over a certain time frame that you're looking at.
Not over a certain time frame, because that's still just profit. So what's profit margin?
The amount of profit made over your expenses.
Over your costs,
Yes.
okay? Okay, so that's the amount of profit that you make over your costs.
It's like extra money.
Like, for example, my father ran a grocery store in a little small town. And at the time, gas was like $1. And he would buy the gas for 98 cents a gallon, and he would sell it for $1. That means his profit margin was 2 cents a gallon. Okay? So what do you think the profit margin is in pharmacy? Is it low or high per prescription? It's very low. On some prescriptions you lose money. On some you make money. Most you make money, but on some you actually lose. But the margin as a whole is relatively low. Because we see there, we've driven it down to AWP minus a certain percent. So that you get paid almost exactly what you get the drug. Maybe you make a little bit of money off of it. And then the dispensing fee, that sounds pretty small, doesn't it? Okay? Now, it works. It works. But, certainly big profits, exorbitant profits, been driven down. So you're right, it's not patient-centric, it's volume-centric. Okay? Because if you make only very little per prescription, then you better sell a whole lot of prescriptions. If I have that lemonade stand on the corner, and I only make 10 cents per glass of lemonade, I better sell a whole lot of lemonade, don't I? Okay. Any other thoughts about this whole process? Is this what you thought it was, or you didn't know? You didn't know what it was? Listening to number 2. Ah, another comment. Yay.
So this kind of contradicts about
Well, you said two different things there. It doesn't contradict do no harm. I would argue that there's not harm being done. But you're absolutely correct in basically going along with the previous comment, about it not being very patient-centered and being more based upon acute, because now, this is how a pharmacy gets reimbursed for selling prescriptions. The problem is that by and large, pharmacies haven't been paid to do other things, to really conduct drug utilization management, medication therapy management, to go out into the community and provide services at health fairs, and do all these other wellness things. Now, the walls are slowly being torn down where pharmacies are getting paid to do those things, but by and large, they mostly still aren't. So this is largely how they make their money. Now, and the issue is, the problem is a lot of chain pharmacies buy into this and have bought into it because this is easy. If they make a few cents on every prescription and they do hundreds of prescriptions, and that's a few cents over and above their costs. So after they've paid for all the costs, they still make in profit a few cents per prescription. And each pharmacy does 500 a day, and they have several thousand pharmacies in the network, the company still ends up making money, right? In fact, they make decent money. So we always clamor as a profession, we're not respected enough, we're not getting paid for services and whatnot. Well, you can hardly look past, and I'm not condemning them all, but you can hardly look past our very own chain pharmacies for allowing this to happen. They haven't been at the forefront of trying to get in the battle to try to get paid for cognitive services, because they've made this model work for them. They've made it work. In spite of the low margins, if you fill several 100,000 prescriptions a day, you make money as a company. Independent pharmacies also operate on low margins. So they have to figure out a way to still make a reasonable profit. And many of them have closed. But some of them stick around because some of them have just better managers that have learned to buy less frequently. Some of them understand and that they make a lot of the pharmacies, and some of you wrote on your Twitter about selling alcohol and tobacco, and I agree fully that pharmacies ought to not be selling things like alcohol and tobacco. But other things, candy and cards and so forth, have a much higher what? Than prescriptions.
Price?
Profit margin. Profit margin is much higher on greeting cards, on candy, on OTCs, and sundries and so forth. So that's where a lot of the pharmacies, including independent pharmacies, make money as well, because the profit margin on these goods is higher than the profit margin on prescription drugs. And I don't know exactly what the profit margin is, but as far as an example, while they might make 10 or 15 cents dispensing a prescription, that $4 Hallmark greeting card, you might actually make $1.25 off of it. So the profit margin of some of these other things that are sold in pharmacies is often higher. But that's the whole system. That's how it works. That's basically how we've gotten to and where we are today, is with this system. For better and worse, this is what it is. just real quick, and I hated to jump over it, but I started talking about pharmacy, and I didn't want to cut that in half and just continue. I wanted to continue talking about pharmacy. So does everybody have a handle on how this works now with pharmacy? Pretty good idea now. The ingredient costs, professional fees. You can understand how some pharmacies, seeing how this works now, particularly independent pharmacies, you can see how some are much more successful than others financially. Some pharmacies just have a whole lot better managers than other pharmacies. Some pharmacists are very, very good at acquiring drugs at less cost than are others. Some run a much more efficient operation where they can sell more prescriptions with fewer hours of pharmacist and technician labor than the other pharmacy that has to employ more pharmacist and technician hours to sell the same number of prescriptions. Some pharmacies operate where they have a very low cost of their monthly lease. Some pay an exorbitant lease on the building that they're leasing to run their pharmacy. So you can see, and we're talking about profit margins, a 2% versus a 3% profit margin is enormous. Because when you're talking about a budget of several million, a 2% versus a 3% profit margin is a 50% difference. It may mean the difference of a profit of $300,000 for the year versus $500,000 for the year. And for an independent pharmacy, that makes a big difference. So you can see how important it is to be an efficient manager and to know your business, particularly if you're an independent community pharmacy. And obviously the big chains have dozens and dozens of accountants and lawyers and all this stuff working for them to figure this all out. Yes?
If you do join one of these plans, are you not allowed to apply say $5 on top of costs?
Well, that's figured in.
Oh, that's figured.
I mean, I didn't even put that in the equation, but that's figured in.
Okay.
So in other words, so what I didn't put in that equation is, okay, so you dispense the 30 captopril, okay, so for the 30 captopril, that might have cost you, say, $7.28. Plus 250 is $9.75. Patient paid $5, so we owe you $4.75. So that comes into it as well. Right. I just didn't put that on there. Yeah, so I mean, obviously they're not going to pay you whatever the patient paid. So you also have so I'm just talking about the total amount you are owed. Some of that's going to come from the patient, the rest of that's going to come from the PBM. So as I've mentioned even in previous classes, there's always this struggle, this monumental struggle between managed care and other entities. So managed care versus PBMs versus pharmacies versus doctors. Everybody's trying to get their share and so forth. We've seen legislative issues like any willing provider. We've actually had some PBMs in the past, and this any willing provider is actually, I think, in over half of states right now. It's usually done at the state level. And that's when an independent community pharmacy, for example, or a small chain, may actually want to participate, and the PBM tells them, no, you can't. Even though there's the agreement, even though the independent pharmacy is willing to sign the agreement, the PBMs, some PBMs in the past have said no. Why would they say no? Why would they say no to one independent community pharmacy who's willing to sign on to the same agreement, say, that CVS signs on to? Why would a PBM not want to include them in the network?
Patient exclusivity, so they include their overall revenue.
Well, to some extent, maybe they would like to keep the network very exclusive, and the reason is that it's administrative costs. That's a whole new contract and a whole that's a lot more money for the PBM to have to deal with, is to have this one independent pharmacy on its contract. That's just more administrative costs for the PBM. So the PBM says, no, well, we're willing to sign it. No, we don't want you. Because the administrative burden of having you, so I already have CVS, and I have like 10,000 stores in my network, and that's one contract. And here you are, Joe Schmo, with your one store, and you fill 122 prescriptions a day. I don't want to bother with it. But some states then have counteracted that with any willing provider legislation, basically saying that if the provider is willing to accept the contract, they have to be let in. That's what any willing provider means. So some states have enacted any willing provider legislation, saying that if, and this would go to for physicians, say in group and network model and HMOs and whatnot, that they're willing to sign a contract. So this often has originated in pharmacy, but it transcends pharmacy. Actually, pharmacy is the origin of a lot of any willing provider legislation, but it actually transcends and it goes beyond just pharmacy. Because managed care is known to be heavy-handed and whatnot, we've seen some states pass a patient bill of rights. These are things like, step therapy has to be adjudicated within a certain amount of time, prior authorizations within a certain amount of time. Patients cannot be denied care under these conditions, just a various host of things. And you've seen various states sign any willing providing legislation. Gag rules. There was some managed care organizations have actually tried to keep physicians from talking with their patients about different therapeutic options and different provider options that can cost less. And so that's being put under a gag rule. That's when you're gagged, it means you can't talk. And so some states have enacted anti-gag rule legislation, means that a managed care organization can't prevent a physician from talking with the patient about different options. Those are just some of the many, many, many things that go on in this continual struggle that we have in our healthcare system. And so who oversees managed care organizations? Well, the ones that oversee CMS patients like Medicare and Medicaid, certainly CMS has oversight. In fact, how many of you have seen the Kaiser commercials? I know they're all over the place. It said that the Kaiser plan has received 5 stars from CMS. I know it's not just in Sacramento. I know it's not just in my house that those commercials are coming on. And I know I'm not the only person in the world watching TV. None of you have. Like sheltered?
All we do is study. 24 hours, as soon as I get out of class, I go study.
Pretty
We're
much.
studying till 2 o'clock in the morning, then I wake up at 5,
It's
then I
really
finish some
good.
work, then I come to class.
Pretty much.
No.
No.
I don't believe that.
We don't have TV.
We don't have TV.
What is TV?
No, I don't watch TV. I don't go out.
We don't
I don't see
own.
any movies.
It's all on YouTube.
I don't do
We
anything.
don't own the
I just
TV.
study.
YouTube, Netflix,
My TV is my monitor for extra screenage.
pretty much.
Hmm? You have cable. And you've never seen Game of Thrones.
You don't have to have cable to watch it.
Who hasn't seen Game of Thrones?
Oh, I love that show. Watch TV, guys.
There's something wrong with you. There's something wrong with you.
Yeah.
If you haven't seen Game of Thrones, there's something wrong with you.
Yeah.
Quit pharmacy school.
Quit it. Your homework. Go home.
If I had a choice
Watch
between
your
pharmacy
homework.
school and Game of Thrones,
Yeah.
I'd definitely take Game of Thrones.
Yeah.
Seriously. Like half of you haven't seen Game of Thrones?
Actually wanted to see
I'm not sure I believe that either. Because I've heard rumors. I've heard rumors that among Toro students, now this was most of the P2 class at the time, that I heard the rumor. I heard rumors there's big Game of Thrones parties.
What?
Yes. We're like, where? Go find the P2s throwing them. I've heard there's big Game of Thrones watching parties.
No.
So you're not, none, this class doesn't do that. It's only the P2s.
Not that much nerds.
You can binge watch, you can have to binge watch several episodes. So anyway, if you were honest and admitted that you watch television on occasion,
I love Game of
apparently you're content to lie, which is okay. So if you're honest, you see that there's actually commercials. And since y'all are so sheltered, you probably won't know the answer to this either. Who's the voice that's actually doing a lot of voice for Kaiser right now?
Is it Jon Snow?
Hmm?
Isn't it a woman?
Is it Jon Snow?
Who?
Jon Snow.
Jon Snow. No, not Jon Snow.
Isn't it a woman?
Allison Janney, who used to play in The West Wing, and now is the mom on Mom, or the grandmom on Mom.
I like her
We don't
voice.
see that either.
I like her voice.
So she's the voice, and she'll say for 7 years in a row or something that Kaiser Medicare Advantage plan has gotten a 5-star rating from CMS. So you'll actually hear that and see that on a commercial if you are truthful about watching television.
You don't have a TV.
You don't have a TV? Oh, I'd kill myself.
Straight up.
Now, there's also a non-regulatory body. Non-regulatory agency called NCQA, National Committee on Quality Assurance. And they accredit managed care organizations, but it's voluntary. And they look at quality management, physician credentialing, in other words, how do they let physicians in, utilization management and all that. But they really don't look at outcomes of patients so much. But they are an accrediting body, and you'll see that the different organizations will get a certain rating from NCQA. Now, going further than that, NCQA has another program called HEDIS, the Health Plan Employer Data Information Set. And that's actually even geared more to help whom? Who is this designed to help? Employers. Remember, who's the client? The client's the employer. This is to help the employer, because the HEDIS is going to have different things on that managed care plan, like patient satisfaction, different measures of patient access, plan stability. That's really important. What does that mean, plan stability? Like, does it wobble? What would plan stability mean?
People going in and out of your plan?
Yes, exactly. Like, wouldn't it be a good indicator that you're a good plan if hardly anybody leaves? Probably be no other better measure there I could think of. If hardly anybody leaves, it must be a good plan. So that's plan stability. So HEDIS will rate all these things, such as plan stability. Now, it's still very expensive. It's still self-reported. It's not like they're actually collecting hard data. It's just self-report. But it is something that's there, and employers definitely do look at that. And obviously, if you're a health plan and you have really, really good HEDIS measures, then that might enable you to what? Charge more. Because after all, if you're running a lemonade stand, and Joe across the street also has a lemonade stand, and you can prove that your lemonade's twice as good as him, say, well, okay, you can pay $2 for my great lemonade, or $1.75 for his sucky lemonade. Right? Right?
Right.
I mean, does the fancy restaurant in mid-San Francisco charge the same amount as Burger King?
I wish.
No. because they're said to be better. So if you can say you're better, you can charge more, right? HEDIS has a lot of measures. It's only the last few years that they're starting to incorporate more drug-related measures. And I wouldn't say they're random, but they're just kind of weird sometimes, considering all the things that they could put in. But some of the examples of things that they use are like patients' hypertension control, which is measured by like their adherence and how much they've been to the hospital and whatnot. Making sure that patients get a beta blocker after they're discharged. Avoiding high-risk medication in the senior population and adherence for meds of various sorts. And then finally, some information on consumer assessment. This is a survey that's actually done by CMS. It's called the Consumer Assessment of Health Plan Survey, CAHPS. In fact, to be honest, I'm not exactly sure what Kaiser's referring to in the commercial, but they're probably talking about CAHPS. But I can't say for sure. Kaiser could be talking about something else in the commercial because they really don't go into the details. But CMS, with regard to their Medicare Advantage plans, for example, they'll survey patients about their experiences with different healthcare providers and doctors, and they actually report the results. It is publicly available. It's not like it's published in the newspaper, but for me as a researcher, for example, I can access CAHPS data and do analysis on it myself. And they'll evaluate experience versus just satisfaction and things of that nature. So we're going to ask you for some more questions. I'm going to close today by talking about some of the things I've seen on your Twitter that were due today and in your last one. Any other questions? Any questions about managed care?
Question?
What's that? Yes.
So as a community pharmacist, are you able to bill an insurance provider for MTM, like reviewing their medication?
That is something that you can negotiate with the insurance company. And usually you will come up and
blood pressure. That's why.
Well, I mean, again, almost anything's negotiable.
Right.
And for the climate has been for years and years that pharmacies don't bother. And slowly, that ethos is changing to where pharmacies may be able to bill for certain services and so forth, and insurance companies may be accepting of that. If you always have to demonstrate value to the person. Because so a person doesn't accept, when you think about when you're trying to negotiate with anybody, okay, the other person doesn't accept your terms just because. They won't accept it because they think you're a nice guy, or they think you have good intentions. Because if they come out in the raw end of the deal, then they don't want the terms. So you always, when you're negotiating with anybody, you always have to show value to them. Okay? So the independent community pharmacy has to say, or even for that matter the chain has to say, if you will reimburse us for this, this is what we will do. And we have evidence to suggest that this is going to keep your patients healthier and ultimately cost you less money. But you have to have proof of that. In other words, you have to show value to the person with whom you are negotiating. So a lot of you wrote about medication adherence, which is really good. And there were different things. There's all sorts of, every day on Twitter, the things about medication adherence. The journal that I edit published a nice paper on using apps and another one utilizing tailored tweets not all that long ago to help people, remind them to take their medication, remind them about the importance of taking their medication, and so forth and so on. Genomics has promised to help people be adherent by tailoring medications to their needs. That's a little note for myself, case of Jimmy Schiffer. Did I ever told you about Jimmy Schiffer? I don't know, because I've often talked about Jimmy Schiffer. Jimmy Schiffer was a pharmacist in New York City. And I began my career as a professor at Long Island University of Brooklyn in New York. So I made that big transition of moving from Louisiana to New York. And Jimmy was an adjunct faculty at LIU. And we were pretty good friends. And he was saying his New York voice, Shane, you gotta come to the store, you gotta come to my store, you gotta come check out my store. So I went to Jimmy's store one afternoon, and it was a typical New York pharmacy in an area of Brooklyn called Sunset Park. Typical New York pharmacy was tiny, 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 tiny. You had to kind of walk through the aisles like this. Typical New York anything, but especially New York pharmacy. Very, very congested. But Jimmy had had just one of these personalities that was larger than life, and just a great business person, and great clinician at the same time. And often people see business and clinical as the opposite ends, and Jimmy had the right way of melding them together. I was there for a little while, and I saw that Jimmy offered a free box of candy to somebody. Oh, that's okay. I didn't miss. I kind of missed part of the interaction that occurred, and then not too long after I saw it again, it was Jimmy telling the person, "Oh, this is the third time in a row you've come on time for your meds," and he offered them an umbrella. So what was Jimmy doing? Rewarding people for being adherent to their medications, and at the same time, guaranteeing their business like gold. Absolutely guaranteeing their business. So there are ways, people. There are ways to be a really good pharmacist. It's not about memorizing benzene rings.
Mm-hmm.
Well, I'm not here to tell you that's unimportant. But there are ways. And I saw Jimmy do it all afternoon. And people had his customers eating out of his hand and rewarding them for taking their medications properly. That's how you be a good pharmacist. That's how you be a good pharmacist. So a number of you write about things with the CDC. We saw that CDC has found that diabetes developing in younger ages than ever before. Now why is that?
High sugar diet.
What's that?
High sugar diet.
Yeah, because we're giving our young children and babies a lot of junk. One thing that when I've taught this course in the past, and I've had more credit hours than is afforded me here, is I've actually talked about these different agencies. A couple of you have written about AHRQ's Project ECHO. Who wrote? I know 2 or 3 mentioned that. What's Project ECHO?
They are not here.
They're getting generalized, they're getting specialists to like FaceTime or video chat general physicians so that they can provide services similar to
And what diseases were they specifically targeting with ECHO?
But I don't have the 20 minutes.
Anybody remember? No, at least 2 or 3 of you wrote about it. So nobody's going to come forward.
I do regret about it.
Is it just because you don't want to be ostracized by your classmates?
Mm-hmm.
Whoever can answer gets a free Game of Thrones party.
Is that Thomas?
Still nobody answered. So it's a never. What is AHRQ?
American
What is AHRQ? Agency for Healthcare Research and Quality. Agency for Healthcare Research and Quality. It is sort of like the policy side of the NIH. What's the NIH?
National Health
What does that stand for?
Institute.
National Institutes of Health. And what does the NIH do?
They regulate.
The NIH funds research. Now they conduct research of their own, to be sure. They conduct lots of research of their own in their vast campus in suburban Washington, D.C. But they're provided billions of dollars by the federal government, and then they release what we call RFPs, requests for proposals. And then researchers, like at Touro, like at UCSF, like at med schools, like at dental schools, like at nursing schools, like think tanks and so forth, they actually compete for the grants. So these RFPs correspond to certain research grants in hopes of finding out the solution to certain problems that the NIH is looking to solve. And so they put out these requests for proposals for researchers to compete and get the grants to then conduct the research and then publish the research. Okay? And AHRQ, so NIH does that mostly with regards to basic science, and AHRQ, in essence, does it with regards to health policy. Okay, so that's what those agencies do. SAMHSA actually stands for the Substance Abuse and Mental Health Services Administration. And they're involved in a lot of initiatives right now. Many of you are writing about marijuana and overdoses of heroin, overdoses of opioid products, even Imodium overdosing, which is one of the latest things I've been hearing about and seeing you write about lately. And so SAMHSA is very involved in programs to try to curb that sort of thing. So there's a lot of FEMA, of course, everybody's, what's FEMA? What's FEMA?
It is Federal Emergency Management Agency.
Good job looking that up. So what does FEMA do?
It goes to...
On the news on CNN, when do they talk about FEMA?
Hurricanes.
It goes to
Right.
natural disasters.
They're the folks on the ground when there's, especially hurricanes, tornadoes, floods, et cetera, helping, providing actual manual assistance, providing money, and so forth and so on. Okay, that's FEMA. That's right. Some of you have been writing about post-traumatic stress. A lot of you have been writing about nutrition, self-medication, lifestyles, complementary alternative medication. In fact, apparently Dr. Bergeron's been talking about some things. A number of you mentioned some things that she's talking about in her class that you found on your Twitter feed with regards to proper nutrition and health and so forth. A big piece of news that a lot of you have written about is what? Children are being given too much medication by their folks. Too high of a dose and too frequent. And that's been really codified and verified in a number of studies. What's happening there? What do you think is happening there?
Chronic diseases?
So, according to the article, the parents are giving the dosage incorrectly. They're overdosing the children because they couldn't adhere to we call it the dosage forms.
Right, so there's several things going on. One is a problem with health literacy and not being able to understand, comprehend, and act upon directions given to you by a health provider. Then that's only complicated that much worse when we're asking parents to figure out the amount of, say, a liquid medication based upon the instructions. Because from what I understand, you guys struggle enough with calculations yourself. Let alone parents who are trying to figure out dosages. And if you're a parent and your kid is really, really sick and you're very worried, are you likely to under or overdose if you can't try to figure it out? overdose, because I want my kid, I'm very worried about my kid, and I want my kid to get better. Okay? But it can be problematic, because even over-the-counters can have drug interactions, and especially children who have underdeveloped enzymatic system for clearance of those drugs. So we're seeing a lot of overdosing in children. Certainly continue to see a lot about prices of drugs, including the EpiPens. Proposition 61. Anybody heard of Proposition 61? There's actually an editorial in the Sacramento Bee this morning on Proposition 61.
Is that to control the prices of drugs?
Well, it's not really to control, although it's an attempt to try to curb the prices of drugs, but it's an attempt to make manufacturers publish publicly the prices of all of their drugs. But as even the Sacramento Bee, as most papers are left-leaning and sort of anti-pharma and whatnot, and even they said that this was not a good bill, because it is very difficult to even quantify what those is. They talk about how that this does not include the rebates that we talked about earlier in class today. It talks about how those would be, the law as currently written only applies to certain drugs, certain classes, and certain organizations, and does not include, for example, the VA and veterans and so forth. So it's a bill aimed to try to reduce the transparency that exists in drug costs. And it's actually going to be on the ballot in November for those of you voting. But it sounds all good. Oh, make big, bad, nasty, mean pharma be more transparent. But just because that sounds good in spirit doesn't mean a bill is well written, and it doesn't take into account the unintended consequences that exist when you pass a bill. And so even the sort of left-leaning Sacramento Bee said this morning to say no on that bill. So just something that I saw a couple of you happen to write about, but I've been seeing a lot of myself in the lay media. Some of you have written about healthcare practitioner education. So pharmacy education, for example, what are we stressing? Interprofessional education. What does that mean?
Working alongside other healthcare providers to share their expertise with each other.
Right, and that's gaining an empathy and an understanding of how everybody else works in the healthcare system, and learning it while you're students working together so that you can have better relationships with these people and greater empathy and understanding of what these people do when you all are practitioners, rather than waiting and hoping it's going to happen as practitioners if you've never been exposed to one another as students. And interprofessional education is much more than you sitting there and having a lecture together with, say, the med students. It's out there practicing together. It's out there working on problems together. And there's even some things there about telemedicine. So actually working on telemedicine projects together as student interns. There are some medical schools now doing poverty simulations to try to increase empathy towards disadvantaged or poor populations by I actually took part in one when I was at the University of Oklahoma Medical Center at the med school there. They actually did a poverty simulation. So they asked faculty to come, and we were given like $100, and we had to get like 10 different services done that day, and we didn't have a car, and we had to try to figure out how to get to this place. But to get to this place, you had to do this and buy a bus pass. But you get to this place, and by the time you get to this place, so it's designed to create empathy, awareness, understanding for those that are socioeconomically depressed. Many of you wrote that, and it's true, that Medicare Part D has actually been shown to be more comprehensive than VA coverage. And I remember one student, I don't remember who it was, but you were right to point out that we talked about in class how extensive VA coverage is. And VA coverage is, in fact, very extensive in terms of the array of services. And they do have a decent formulary But the Part D formulary, while there is a little bit more cost sharing with Part D, the Part D formularies of most plans has actually been shown in recent studies to be superior to that of the VA. And a lot of you have been writing about different things about research. How many of you watched the John Oliver thing that I sent you? Hold your hand up high if you watched the John Oliver thing I emailed you.
Night show.
The
Yeah.
studies.
Watch it. It's funny.
funny.
And I don't even like John Oliver.
It's really funny.
And it's funny.
Yeah.
It's very, 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 very edifying. It's very funny. It's hysterical. And it's very educational. And they show, for example,
It's a long
Kathy
thing,
Lee and
though.
Hoda
It's 19 minutes.
drinking a glass of wine. Hey, we just had research that says that a glass of wine is better than one with jam.
It's a really good, like...
And it's true, and just yesterday I saw that, my wife was watching some news magazine shows, hey, new research says that, you know, smoking heroin is better for you than candy. Oh, says everybody, let's start getting on some heroin. And that's, you know, because if one really poorly designed study that really wasn't even published in a reputable journal, or otherwise, even if it's a decent study, they'll take one little snippet of it that was not at all the big picture, and they'll take one little piece, and that 3 words, just like you know, when the movie reviewers say like this was a awfully, like a terribly great, like a terribly bad movie or something, they'll say bad movie, like it's a compliment. And they say they take 2 words out of it. That's what they do with studies. They'll take like 3 words, and then all of a sudden it's on all the news shows. And they also some of you also talked about FDA and NIH both cracking down on transparency of clinical drug trials. They want the results of all clinical drug trials published. You know, that doesn't mean like published in a newspaper every day, but widely available. Because currently, we're more likely to see positive than negative results of clinical drug trials that are published, or clinical trials of anything for that matter. And so there's a push now to get all the results, including unfavorable results, published. And adverse selection, moral hazard, some of you wrote about adverse selection, and that's what's kind of going on with some of the Obamacare plans. That's why some of them are getting much more expensive, because some of the more sicker people that are in it, that's driving costs up. So there's a lot of good things about Obamacare, but there's also some adverse selection going on. It's increasing price right now for existing market goers. And a lot of you talked about screenings, which gets into epidemiology, which I don't have time to get over, but I wanted to talk about primary versus secondary versus tertiary prevention. And so as I emailed you yesterday, I'm actually going to finish up this discussion on we're done with managed care, but I wanted to discuss with you a little bit about professional organizations and also a little bit more of health disparities. And I'm going to do that after your guest from Covered California talks to you on October 13th. So have a good rest of the day.
Thank you.